Right.
A very good afternoon to everyone. I welcome all the speakers and the attendees for this session. Now, on the behalf of Voice of Healthcare and Zydus, I welcome my guest speakers and attendees for this second episode as a part of our current virtual series of discussion to mark Men's Health Awareness Month, that is November 2021, via a series of virtual discussions. The theme of which is Men's Health Forum, Remember in November. The topic of today's session is screening and diagnosis of prostate cancer in India. And to speak about it, we have this esteemed set of panelists with me, whom I'll just go ahead and introduce. First up, we have Dr. Mohan Keshav Murthy. Sir is the Director of Urology, Uro-Oncology, Andrology, Transplant and Robotic Surgery at Fortis Hospitals, Bangalore. Then up we have Dr. Neeti Raizada. Ma'am is Director, Medical and Hemato-Oncology at Fortis Hospitals, Bangalore. We have Dr. Harish P. Vedas. Sir is Senior Consultant, Medical Oncology at Site Care Hospitals, Bangalore. When we have Dr. Ravi Gaur, Sir is the founder at Dr. G Path Labs and advisor on board at Spice Health. And then up we have Dr. Nitin Yashas. Sir is a medical oncologist and hemato-oncologist at Manipal Hospitals, Jayanagar and Sarjapur, Bangalore. Co-founder of Alto Doctor. This is a platform for doctors to express themselves and indulge in the creative pursuit and hobbies. And also, while sharing his expert views and opinions, Dr. Nitin will also be leading this conversation. So, further, I would just like to hand it over to Dr. Nitin to take up this conversation. Over to you, Dr. Nitin.
Right. So thank you, Kushbu and Voice of Health for talking about this very important topic, which sometimes is neglected. And I think there's a sort of whole symmetry to it that in October we are celebrating breast cancer awareness and women's health. And in November, we are talking about prostate cancer and men's health. Of course, we have had quite a few celebrities who were diagnosed with prostate cancer, some of them from abroad, such as the famous music director Andrew Lloyd Webber, Charlton Heston and Sidney Poitier, some very acclaimed Hollywood actors. But over the years, prostate cancer, so to speak, has not received that much of attention in terms of awareness. And we all know that moving forward, the incidence of prostate cancer is indeed increasing. At the outset, I would really like to thank Voice of Health for having me on this panel with such esteemed clinicians in the field of oncology. It's my pleasure to be sharing this panel with Dr. Neeti, Dr. Harish, Dr. Ravi, and Dr. Mohan. So I would like to start off with Dr. Mohan and ask him, sir, what in your experience is being the current presenting age of prostate cancer in India, and what are the symptoms that you are seeing them typically present with?
Thanks for having me on the show. The of cancer prostate in the Indian scenario, we tend to pick it up incidentally when they come for a master health checkup, or we do a TURP with normal PSA and the histopatch shows cancer prostate, or the patient comes with metastatic features and then retrospectively, based on the metastatic features, we go ahead and do a transrectal biopsy and pick up a cancer prostate. The age, unlike the Caucasian population or the Afro-American or African population, is generally 60 plus. We don't see it at a younger age group, and there's not much of a familial pattern in the Indian scenario at this point in time. So in summary, not many specific symptoms, age is 60 plus, and most often picked up incidentally.
Sir, to just follow up on what you were telling.
Hello?
Yeah, so just to follow up on what you were telling.
Hello? Could you hear me?
Yeah, we could hear you. You're clear. I just wanted to ask a follow-up question that in terms of symptoms, do all elderly men with lower urinary tract symptoms need a dedicated urology evaluation and in fact screening for prostate cancer? I think till Dr. Mohan comes, I would like to ask Dr. Harish this question, that in your practice, sir, over the years, with people coming in with, a health checkup showing elevated PSA
Hello?
or presenting with metastatic disease, in your experience, how many of them have you actually seen present with metastatic disease
Unable to
upfront
get on it.
rather than in
It
the
says
initial?
open it in Chrome. Open
Okay.
in Chrome and it refuses to.
Typically, around 80 to 85% of the patients whom we see are usually we are seen at an advanced stage. Hardly 10 to 15% of the patients do come with a screen
Can
detected
you hear
PSA
me?
detected tumor. So yeah, I would say more than two-thirds of the patients we are diagnosing at an advanced stage, as compared to Western countries where less than 10% probably they find it at an advanced age. So that is the difference. Western countries, around 10% do come at an advanced stage, and more than 90% are sort of screen detected prostate tumors. In our scenario, it's exactly opposite. 80% is a advanced stage, and 10% is probably screen detected tumors. However, recently there has been some change, and many patients are now being diagnosed at an early stage by screening methodologies. Yes.
I think that's a very, very interesting point that you have made there, Dr. Harish, that as compared to the Western countries and presentation, in India, typically the symptoms may be ignored. People do not go necessarily for a test immediately, attributed that it may be due to benign prostatic hyperplasia, which is also seen commonly in this age group and really present at an advanced stage. I would like to come to Dr. Ravi before I come to Dr. Neeti here, that in your opinion, sir, how reliable an indicator is the PSA testing, and would you have any suggestions that elderly male with urinary symptoms undergo the PSA testing? PSA, for all those who are watching this show, is the prostate specific antigen test, which is a blood test being done.
Good afternoon, everybody. Nitin, I think this is a very relevant question. And in fact, Dr. Harish, what mentioned is, I think the problem across all cancers. In India, the screening is really not taken that seriously. And that's the reason probably majority of the cancers patient come to us or come to the oncologist probably in stage 3 and stage 4, that's 60-70% of them. So I think PSA is one such, it's a silent kind of a thing, because as Dr. Mohan is mentioned here, right, the PSA is something which is can be seen, especially in benign prostatic hyperplasia over 50 years of age. And it can even be because of the urinary tract infection. But yes, the recommendation, I think it started way back in 1986 that PSA should be part of the routine screening for everybody above 50 years of age. If they have not in the symptom, but the routine screening. But then I think somewhere, there was a question of overdiagnosed, there was some underdiagnosed, because there was a lot of silent cancers that came up. They were incidental findings. They were no symptomatic, probably at the time autopsies they were found, and maybe just a routine sometime. So I think somewhere 2008, there was a lot of debate going on the worldwide, and they said PSA, earlier it was like they started 40, 45 years, but now I think, yes, anybody beyond 50 years of age should definitely have a screening for PSA. And if they have a symptom, definitely that's more important. And if they have a family history, then PSA is definitely one of the the screening markers one should regularly get, at least on an annual basis, and consult their oncologist whenever it is raised. That's something that currently I'll suggest from my desk.
I would like to come to Dr. Neeti here. And most of the times we have patients or even healthy people coming to us, oncologists, and ask that, look, my grandfather had a prostate cancer, or someone I know have a prostate cancer. Is there any way we can detect prostate cancer early? And so would just like to know your opinion, ma'am, as to what should the recommendations for screening be in our scenario, looking at the Indian population, in patients who do not have a family history, should PSA be mandatorily done as part of all health checkups in the geriatric age group? And if those who have a family history, would you suggest that we start PSA screening at an earlier age?
Thanks, Nitin. And thanks, Voice of Health, for calling me today. Well, let me start from the beginning that PSA is a very simple method of assessment. It is a glycoprotein which is found in blood, and just a blood test can suggest that there's a possibility of being something abnormal in the prostate. But the downside of finding out whether PSA is high is that you may sometimes do unnecessary biopsies when it is really not relevant. So the guidelines today is first evaluate the patient, find out whether there is any history, there's any lower urinary tract symptoms. There, as you asked, very pertinent, that is there a relevant family history? Is there a pertinent ancestry? Any African ancestry is considered as high risk. Family history means whether you have history of not just prostate cancer, but pancreatic cancer, breast cancer, and other relevant cancer, including endometrial and colorectal cancer in first degree relatives. First degree relatives are your immediate relatives like your parents or your siblings or your kids, or second degree relatives, and at what age they had. And then certain other risk factors. Already a person is taking some drug for benign prostatic enlargement. All these need to be evaluated. And then the guidelines, at least in the West, is between 45 and 75, this blood test has to be done and should be done along with digital rectal examination. In our country, we don't have any fast guidelines, but between 45 and 50, the first PSA should be done and should be repeated either annually or 1 in 2 years. And then again, as I said, it should be clubbed with some other investigation. I mean, it could be definitely digital digital rectal examination. But we have to remember, as Dr. Ravi also mentioned, that if there's a coexisting inflammation or infection persistent, and then we have to see whether this velocity, the PSA, has been consistently high, or is it increasing or it is reducing, known as a PSA velocity over a period of time. A very high value at presentation, if we already have a value of 50 or 100 at presentation, definitely needs a further investigation. But we have a borderline value of 3 or 4, then we may want to reconfirm before we subject the patient for a biopsy.
I think
Nitin, I'd like to add just 1 minute here.
Sure.
What Nitin very relevantly said, when we talk about PSA today, nowadays, in fact, there's a lot more, improving version of PSA test. And we have something called free PSA versus the total PSA ratios. Now, that's something which are also been detected whenever there's a doubtful cases for that matter. In benign prostate hyperplasia along with UTI. So when you have a PSA probably testing and there is something in the higher side, go for other things. And we also have a PSA density of transition zone. That's something, a PSA value, and with the transition zone, which is actually the interior part of the process surrounds the urethra. Then age-specific PSA difference is also there, because sometimes at 60, 70, probably the PSA normal range is about 3 to 4, but anything beyond, I think age-specific. So I think PSA has to be seen not in isolation, but I think it has to be seen the family history, examination, digital examination, and the age and multiple other factors. PSA velocity is the important factor, how it is growing. And that's something I'd like to add on here, and be careful when you're doing PSA.
So before we just sort of move on to the next segment, just to sum up for those who are watching this based on what our esteemed panelists have told us, most important thing is do not neglect any symptom of lower urinary tract in the elderly people or at any point of time, and have an evaluation done by the urologist. PSA, a simple blood test which can be done, but it cannot be used as a definitive screening test. And as like all our esteemed panelists have said, a PSA has to be taken in account with a family history, with the ancestry, and also a digital rectal examination done by the urologist. And hence now I would like to ask Dr. Mohan here that, again, we said a lot of elderly population do present with urinary complaints. And we say that a diagnosis of cancers in most tumors is not achieved without a biopsy. So there are a lot of myths about biopsy. Some people hesitate to even go for a biopsy, thinking that a biopsy will increase the chance of spread of cancer. So if you could shed some light on when would you recommend a biopsy for a patient? B, is the procedure of biopsy painful? And C, for the general public, does doing a biopsy actually increase the risk of spread of cancer?
Excellent question, Nitin. The point here is there is immense fear in the general public of undergoing a transrectal biopsy. First of all, it's an area where most people would not want a needle going through. Second, there is this irrational fear that cancer may spread if a needle goes into the cancer. Now, having said that, we have moved from the era of finger-guided biopsy to transrectal biopsy in most centers in the country in major metros, although finger-guided biopsy remains a technique of choice for the lack of ultrasound equipment in secondary cities and smaller places where qualified urologists do practice. The need for biopsy has to be balanced against an elderly gentleman who has come with lower urinary tract symptoms and or a urinary tract infection symptoms. What we generally do is give a course of 2 weeks of antibiotics in case the PSA is elevated. Here we are talking only of the total PSA. And if the symptoms do settle down and the repeat PSA is below 4, then there is no further need in this particular gentleman to continue with the thought process of whether the gentleman has cancer. If not, as suggested earlier by Dr. Niti, we will have to do PSA velocity and density as well as free PSA to total PSA ratio, as well as the transition zone specific PSA and age specific PSA. So these are all subsets which we can look at subsequently. In general, in clinical practice, a 2-week course of antibiotic, a urine culture, if negative, then empirical. If positive, according to the culture, wait 2 weeks, see whether the PSA comes within the baseline, and then go ahead. Of course, reassurance matters. And in our particular center, we also have the facility for MRI fusion biopsy in case the PSA continues to be elevated, even if the biopsy is negative. So there are a variety of modalities in advanced centers where it is possible to decide who needs a biopsy and who needs a repeat biopsy. So in summary, it is essential to counsel the patient about the need for biopsy. Ultrasound-guided transrectal multi-core biopsy is the way to go. A course of antibiotics, to be sure, as Dr. Niti commented, unnecessary biopsies are not done, is essential. And then a culture-specific, culture negative status is essential prior to going ahead with the biopsy.
Just one follow-up question here, Dr. Mohan, and that is that there may be people watching this and they may say that, okay, is there any PSA level at which you would say, let's directly go ahead with a biopsy rather than give a trial of antibiotics? Would you sort of look at any level and say, no, this is looking too suspicious, about this level of PSA, I would directly go with a biopsy?
When I was still practicing in North America, a PSA more than 10 would possibly be a baseline at which I would say, if the patient doesn't have any irritative symptoms of lower urinary tract, no irritative LUTs, I would suggest possibly a biopsy would be a better place to go ahead. Or if the patient has already received a course of antibiotics in the previous 3 months and come back with the same symptoms. In the Indian scenario, in the absence of urinary tract infection, either by symptoms or culture proven, I would go ahead with a biopsy if the total PSA value is more than 20. After counseling the patient of the pros and the cons of going ahead without a course of antibiotics prior. Age group greater than 65, PSA greater than 20, no UTI symptoms or has been treated for UTI in the past with a persistently elevated PSA more than 20, would go ahead with a biopsy.
So I think very important points being... Yeah,
Nitin,
sure, ma'am. Please.
Actually, I mean, the data says that, I mean, there's a 70% probability of a biopsy being positive if the PSA is more than 10. And if the PSA is between 4 and 10, the chances of it being positive is 20%. So I think going by that number, 10 can be a good cutoff. But as Mohan sir rightly said, I mean, in Indian scenario, sometimes we have to individualize our decision. And then probably a higher value may be useful.
And that's sort of the most important thing that we are sort of bringing out from this discussion, that these days guidelines are available for everyone out there to read on the internet. But it's very important that as clinicians and even the patients understand, in the Indian setting, we have to individualize most of the decisions. So anywhere between 10 to 20, discuss with the patient and offer them the biopsy, because the chance, as Dr. Niti said, is definitely more than 70% of it being positive for cancer. more than 20, no symptoms of urinary tract infection, I think a biopsy becomes very pertinent to be done at the earliest. I would like to come to Dr. Harish here. And these days, if there is one word which is sort of synonymous with cancer, it is PET-CT. You tell a diagnosis of, or even a suspected diagnosis of cancer to a patient or the relative, the first thing they ask before a biopsy is PET-CT. Somehow I feel that Indian patients and relatives are more comfortable with PET-CT rather than biopsy. But we know that for prostate cancer, the usual PET-CT is probably not adequate enough for staging. So how would you go ahead and stage a patient if he or she has been diagnosed, if he has been diagnosed with prostate cancer?
So prostate cancer is not a single diagnosis. So when we see the patient, we see a variety of symptoms. Basically, it will be a symptom-based evaluation that we do. For a typical patient who has come with a prostate tumor, he has multiple issues like backache, loss of weight, and he has some MRI which or any scan which shows a metastatic disease. There is no need to do any further scans apart from whatever has been done. We can, and especially if the PSA is high, we can just monitor by PSA regarding the disease resolution or progression. There is no need to do any other scans. And as compared to yes, they not only for the patients, even the doctors are also doing more scans, the PET-CT scans in India. That is another discussion altogether. Now there is a special scan called PSMA scan for prostate carcinomas, which can be used for initial staging as well as for further monitoring of the disease. But it is not like all prostate cancer patients do need to undergo PSMA scan or specific prostate PSMA specific scans. So it's an individualized decision that we take regarding the further staging workup, as well as if there is a treatment discussion which we may have to do. So typically PSMS, so there is a, when we diagnose a prostate carcinoma, there is something called risk stratification. We do it very low risk, high risk, intermediate, very high risk. So there are certain risk stratification we do in prostate cancer. Probably I would be doing a PSMS scan if it falls into intermittent or high risk prostate cancer, where I need to individualize the treatment, whether the disease is located only inside the prostate, where there is extra prostatic extension, are there any regional lymph nodes which can be involved. These are the situations where I may end up asking for PSMS scans. Otherwise, routinely, not for all patients, we need to do a PSMS scans.
So just to tell our viewers out there, I'm sure of a radio labeled glucose diet, but for prostate cancers, especially those who have a high PSA level, now we are able to use special dyes in nuclear medicine which would be able to target specifically the proteins secreted by the prostate cancer cells, and that is how the name the PSMA PET scan has arrived indeed. So just would like to get in Dr. Neeti's opinion here, that in her experience, in which stage or in which situation would she definitely recommend a PSMA PET scan for a patient diagnosed with prostate cancer?
So, Nitin, that's a very tricky question. A prostate-specific membrane antigen scan. I mean, see, I think what data Harish gave is probably based very center-specific. We get a lot of early-stage cancers as well, because we have a very dominant uro-oncology group also in our system, and we get a lot of references, at least to review. And how, I mean, as everybody mentioned, that we will try to risk stratify them initially. And if a metastatic case comes to me, and when I have to quantify that metastatic, whether the patient is hormone refractory or castrate resistant, or the patient has low risk or high, I mean, low tumor burden or high risk, high tumor burden, in that situation, I would definitely want to do a PSMA PET CT. But in a person who has localized prostate cancer, and our choices are only between doing some local therapy like radiation or surgery, or sometimes only putting them in observation, that time a good local assessment is enough. So either a local MRI whenever feasible, or if required, I mean, based on the urologist's recommendation, if they have any specific need for a local staging, that can be done. But when the patient comes to us and the patient is already metastatic and I have to quantify the tumor burden, then I would want to do a PSMA PET scan.
Nitin, can I come here and add a point?
Sure, sir. Sure.
As Dr. Niti mentioned, we get a lot of patients early stage, organ confined, biopsy proven cancer prostates. Then the first indication for a PSMA PET is if we decide to go ahead with the intention to cure versus intention to control. If the intention to cure can be radiotherapy or radical surgery, in which case to stage we use a PSMA PET. The second is if we post-operatively in follow-up, we find that the PSA is doubling twice in a short period of 3 months. Then we go ahead with a PSMA PET scan to find out is there a local recurrence or is there a distant recurrence which we have missed at initial diagnosis. And the third point, as Dr. Niti said, if we decide to put the patient on adjunctive treatment and the PSA doesn't drop down to below 1, closer to 0.04, then again for change of protocol, adjunctive protocol, from the perspective of the medical oncologist, we use a PSMA PET. In summary, three definitive indications in our setup for PSMA PET. One, to stage it in organ confined prior to definitive therapy with the intention to cure. Second, post-operatively, if we find the nadir PSA doubling twice within 3 months, because we are then looking for a recurrence. Third, for change of an adjunctive protocol because the PSA is not dropping down to the baseline prior to consultation of the medical oncologist. These are the three typical uronc situations in practice that we use PSMA PET.
And I think a very valid point made by Dr. Niti that it's very sometimes center dependent too, because in our center, we sort of see a little more advanced cases of prostate, and hence, by virtue, we sort of are pressed in a need to do more PSMA PET scans. But the good thing out for the public is that as compared to a conventional FDG PET scan, the technology is now available in the city in various centers to do a very specific PSMA PET scan for prostate cancer. I'd like to bring in Dr. Ravi here for something that Dr. Harish mentioned, which was about risk stratification. And a lot of it depends on the biopsy which is sent to the laboratories. So purely from a lab perspective, Dr. Ravi, how many samples of biopsy that we typically say a core biopsy would you require? And sort of many patients look at the grade and they get confused with the stage. Many times, if something is written as grade 3, grade 4, there's a sort of perception that we are talking about the stage. So what would your opinion be on the Gleason grading, which is used for prostate cancer, and how accurate do you think it is based on the biopsies that is sent?
I think this is one of the important things you mentioned about asking. The question is about number of pieces, I think. As a pathologist, we normally, I'll recommend, and generally what's practice is, because clinicians, of course, are their surgeons, at least 8 to 10 probably. The pieces should be there. When you do a single little biopsy, probably you have to do something 8 to 10 pieces, and generally, academically, even 10 to 12 they recommend. But I think 8 to 10 pieces should be there in a biopsy to have a really full picture of the entire, because whenever even you have a TURP, when you have a normal prostate resection, I think there's a word of caution here, because whenever you have TURP, probably you have some 15, 20, 30 pieces or even more than that. So for a pathologist point of view, the standard protocol for all pieces, whatever we get, everything has to be processed, because you may not get the desired the picture. Maybe if you have a 30 pieces, the 29 pieces probably will have normal, and one piece will have some focus of malignancy, because that's something what is seen. So when it comes to number of pieces, I think when you do a little biopsy, at least 8 to 10 pieces are required, and I think that is the protocol generally followed in majority of the hospital to arrive at, because you may not, otherwise you'll miss out certain time. The silent cancers, which are normally sometimes is not even diagnosed, and they're diagnosed at the autopsy point. That's the first part. Now, the the second important point is the you mentioned about the staging and the grading. I think yes, there is a lot of confusion between the patient mind. What is the staging and what is the grading? They and with it, I think as a pathologist we talk about the Gleason grading. I think, and that grading is basically based on the kind of you can cells we look into the microscope, and we how different they are or how abnormal they are from the normal. So variation from normal to abnormal. So we grade them based on the scale of 3 to 5, and then probably have a some couple of areas and identify and grade the two scores and the average out, and that's how the grading comes out. That's a Gleason score is something, and grade, and then once you have the Gleason score, then we probably put them into a 5 grades, and those grades are like Gleason score is 6 up to 6 and below. That's called as grade 1 group, and Gleason 7 score is 7, grade 2, and again grade 3, grade 4 is the 8, and grade 5 because it's 9 or more than that. So if the score is or grade 1 is likely similar to be normal cells, and cancer likely to grow very slowly, if at all. The higher the grade, the chances are that it's going to be more aggressive and it's going to grow faster, and that's what the Gleason score is. Also, probably we have some role in pathology and staging point of view. Sometimes we have, because staging is a clinical more picture, because radiological picture at the time of surgery, the surgeon is examined, or local lymph nodes, local invasion, what has happened or not, distant invasion. So we have TNM staging, tumor nodes, I think, and the metastasis. I think that's a staging part. That's something is done in totality. Probably in prostatic, from our point of view, pathology, we just say whether it's just outside the capsule or just neighboring lymph nodes have come or not, probably just invaded the capsule or not, or vascular invasion, we leave it to that. But I think when you do a PET scan or a MR finding, clinical examination, all put together, the tumor size and and that's where we come, and the distant metastasis, because it's sometimes prostate is known to metastasize to bones, even remote or a distant location. That's a TNM staging. I think that had to be more of a clinical pathological together. And for Gleason score is, I think, what we do with the grading from a pathologist point of view. The higher the grade, more is the risk. And similarly, the TNM score, tumor size, the node, and the metastasis put together by the clinician and pathologist. Depending on that staging, we stage. That's the difference between the two, and that patient should not confuse about it.
And I think very valid points to just summarize that when the treating oncologist or the urologist makes a decision, it's regarding how aggressive the cancer is based on the grade, the PSA level, and also other features which are looked on to risk stratify. We are, of course, entering into a very, very exciting time in terms of molecular oncology or in terms of genetic studies in the field of prostate cancer. Something which was not there a decade back, because a decade back on the Times magazine cover, we had Angelina Jolie being pictured talking about the BRCA effect, also which BRCA genes, which also became known as the Jolie effect, because once Angelina Jolie declared that she had the BRCA gene and she underwent removal of her breasts and uterus, BRCA gene became a hot topic. And now we have research and data to show us that the same BRCA gene is being implicated in prostate cancer. So if I could get both Dr. Harish and Dr. Neeti into this question, that when would you suggest BRCA gene testing for patients of prostate cancer? If we could start with Dr. Harish and then move to Dr. Neeti. I think Dr. Harish, Dr. Neeti, if we could start off with you.
Nitin, in the meantime, can I add on the previous question?
Sure, no problem.
If the PSA is more than 20, the recommendation is only 6 cores are enough. And if it is, any other prostate biopsy, 10 to 12 cores is what we normally see when we are checking the biopsy report. So about genetic testing, well, again, it depends on whether the disease is localized or it is disseminated. And if we have any therapeutic implications of doing a genetic testing. So for early stage, when we are doing genetic testing, it is for deciding whether it's a low risk or a high risk. And in that case, do we need to put an observation alone, or do we need to do any specific treatment? For advanced stage, which we as medical oncologists normally deal with, well, there's a lot of emerging data saying that we should do HRR panel. And this HRR panel not just includes BRCA, but it has a bunch of other autosomal dominant genetic mutations. which also decides whether they can be used as a therapeutic target in certain instances. So normally, I mean, the recommendation is to do this HRR panel, a somatic mutation panel at baseline when there's a metastatic prostate cancer. However, in clinical scenario, most of the time we do when there is progression of a metastatic prostate cancer and when we are looking for more options. So when we have exhausted our frontline options, giving a higher generation hormones or probably trying frontline chemotherapy, and we are looking for further options, we try to take a fresh sample, which is not a bone, and in that tissue, we try to do somatic mutation panel, which is known as HRR panel, which includes BRCA, to see whether we can give drugs like PARP inhibitor. At the same time, in this tissue, we try to do MSI testing and see if there's a role of immunotherapy.
Dr. Harish, if you have joined us back, if you could
Yeah,
add
sorry,
in.
I had just left it there. Yeah.
Sure. So just talking about the role of genetic testing in prostate cancer, Dr. Neeti has already covered few points. From your side, in your clinical practice, whom would you say that, yes, we need to do the testing for BRCA and other cell repair genes which are present, or to explore options for immunotherapy?
So the indication is castrate-resistant prostate cancer. All patients of CRPC, we would like to do genetic evaluation, which may be of use, may not be of use, but the indication is for all CRPC, regardless of the age and family history. If it is younger age and has family history, more pertinent. But regarding testing, I think all CRPC should handle.
Okay. And just to add on a point here for discussion, I think again very important that from a clinical setting, even if we sort of see an early prostate cancer, which is not advanced disease, but presenting at a young age, it may be worthwhile to explore, is there a genetic component on it? Because like we always say, there are treatment implications for the patient on progression or on becoming castration resistant. But more importantly, we always believe prevention is better than cure. So it makes sense to sort of do it even in those who present at an early age, even if it's an early stage, to sort of test the family members if it comes positive. Dr. Mohan and Dr. Ravi, would you also, one most important thing that I would like to ask Dr. Ravi before I come to Dr. Mohan is, most of the time, sometimes when patients move from one center to another, or even otherwise, there may be a lack of tissue. So from the pathology viewpoint, would you say that these genetic testing being done on blood at upfront, if the clinical oncologist, the medical oncologist or the urologist decides, is also a worthwhile option?
One important thing, nothing like tissue. If you have a tissue, it's always better to do the entire, the genetic testing on that. Blood, and there are now, we're talking about circulating tumor cells and a couple of things, newer testings have come. But I think I'll still say, like, they're all in the validation phase. And let us, they like circulating tumor cells came up, or liquid biopsy kind of thing is not talking about. But I think it's better to go for a tissue because they're all still in the validation phase. And even I think some people are doing not testing with done, genetic testing, especially in urine samples also. Repeated urine sample, they kind of a thing will come out with this, but nothing like a block and a tissue. I like to add one important thing here, because I think when you do for some things, especially with the family, the BRCA testing, I think BRCA testing is definitely probably getting much useful. Because the faulty BRCA2 gene especially can lead to the aggressive prostate cancer. I think that's where probably deciding the therapy. Similarly, things people are talking about now in oncotype DX. So the oncotype DX is being done, and again, probably that's something has been done under the family history and the younger age. Probably it shows the aggressiveness of the prostate cancer. So I think that's what I want to answer. We can do it in blood, but preferably nothing but tissue. Circulating tumor cells, liquid biopsies are coming up, but they need a lot of validation today.
I would come up with a different perspective. One half of the patients in the pre-COVID era we treated for cancer prostate at Fortis hospitals used to come from be Africans or Afro-American. And in them, if there is a family history of at least one another male member having suffered from cancer prostate, upfront genetic testing would be done. I have the privilege of working alongside Dr. Niti on a common platform on a regular basis, as a WhatsApp-based tumor board, where we would decide who would need genetic testing specific instance of Africans or Afro-Americans. But coming to the Indian population, genetic testing is a useful tool, but an expensive tool. At this point in time, it's not even a standardized tool. What set of genetic tests would you do in a given scenario? It's extremely center-specific, it's extremely city-specific, and in a center like ours, what SRL can do is what we will do. Having said that, if there is another male member in the family with diagnosed cancer prostate, then would do genetic testing. The second part of the story is would always prefer tissue. Even patients traveling for a definitive or advanced cancer prostate treatment, we would ask them to bring their blocks and slides with them of the original biopsy, so that if genetic testing is needed, there's tissue and not just blood sample to be taken.
And I think very, very important, and that is something that centers like Manipal Hospital and all the other cancer centers here, that like Dr. Neeti also mentioned, it's very important to educate the patient that it's not just a history of prostate cancer we are looking at, even a history of pancreatic cancer, a history of breast cancer, should raise suspicions that yes, there is something genetic which could be happening, and yes, it would be worthwhile. From our perspective, from my perspective rather, from our experience at Manipal Hospital, sometimes tissues are not available. Sometimes, like Dr. Mohan rightly said, we do not have a standardized panel of genes to be tested on the tissue. But over the years, we know that we have sort of validated the BRCA testing in the blood, and the germline BRCA testing has been sort of validated in breast cancer. So we sort of use the similar experience, and in patients who present at an early age of prostate cancer, or those who have a family history which points towards BRCA-ness, as we talk about, we feel that it is worthwhile to send a blood for germline BRCA, because at least that is more or less becoming cost effective with a lot of labs offering it. So we will now briefly talk about, in the last segment, treatment. So I will come to Dr. Mohan first to just very briefly talk about, if a patient is diagnosed with prostate cancer in the early stages, what are the treatment options that he or she would have available?
Ideally, I would offer definitive surgery for an organ-confined, intermediate-grade Gleason, a surgical option. I would also counsel the patient that there is a radiotherapy option with equal efficacy. The surgical option today can be open, laparoscopic, or robotic. These cancer cure rates are similar with open, well-done open or well-done laparoscopy or robotic surgery, but the prevention of complications, that is incontinence and impotence, are far superior with nerve-sparing robotic radical prostatectomy. So in summary, if the center has robotic experience, nerve-sparing robotic radical prostatectomy for intermediate grade organ confined cancer would be the treatment of choice. Would, however, counsel such patients that they're eligible for radical radiotherapy in a similar setting. In higher Gleason, 8 to 10, adjunctive treatment would be inevitable. The patient has to be counseled with multimodality treatment in a formal tumor board prior to going ahead with radical surgery, even if it is organ confined. In lower Gleason, at least Karnofsky's life expectancy scale has to be brought into consideration, as well as the option of the patient in suspended animation, just following up with periodic PSA, doing nothing. So in summary, intermediate grade, organ confined, nerve-sparing robotic radical prostatectomy, if the robot is available, is the technique of choice. Higher grades, yes, you can offer surgery, but adjunctive treatment has to be counseled and decided upon prior to performing the surgery. Radical radiotherapy is an option for surgery, and in low Gleason, suspended animation versus treatment, aggressive treatment with intention to cure in organ confined cancer is patient specific, individual specific, and we will have to counsel the patient and look at whether they have life expectancy of at least a decade of quality life at the time of diagnosis.
I think from the oncology perspective, we are seeing a surgeon being quite generous to the radiation oncologist, because most often the debates that we come across, even in our tumor boards here, is when a patient, does he go for surgery or does he go for radiotherapy? But I think very beautifully summarized that essentially it's about, and that's what we sort of do here, a multi-tumor board discussion, and then counsel the patient about the pros and cons of opting for a surgery approach and opting for a radiotherapy approach. And it's essentially what the side effect profile which the patient desires. Ultimately, I think that would be the clinching factor. I think the role of medical oncologists are not much in the early prostate, though we are trying to inch our way there with all the molecular talk that we are doing. But I would like to come to Dr. Harish and Dr. Neeti here, that even if it is stage 4 prostate cancer, generally we sort of give a very dismal prognosis for stage 4 cancers for other tumors. But the field of oncology is advancing, and more so in prostate cancer, which is believed to be an indolent, slow-growing prostate cancer, that even in stage 4, we sometimes talk about survival lasting for years. So I'll come to Dr. Harish to first talk about hormonal therapy. Now, people sometimes have misconception about hormonal therapy, that it is limited only to breast cancer or the women's cancers. But I think hormonal therapy forms the backbone and the mainstay of prostate cancer. So in the month of November, where we are talking about men's health, I don't think it would be I think it's very, very apt if you could shed a light on hormonal therapy being the backbone of prostate cancer.
So, for general public, so I think we should rename prostate cancer. Actually, the term cancer has got its own, what do we say?
Negative perception
Stigmas associated with it. Unlike other cancers, prostate cancer, you can say, is something similar to hypertension, uncontrolled hypertension, or an uncontrolled diabetes, or a long-lasting congestive cardiac failure, heart failure, or something like that. So, my idea why I say this is, unlike other cancers, which are even in stage 4 prostate cancers, they behave in something like a hypertension or diabetes. That means the disease can be controlled, and the patient can be kept symptom free for years together, long amount of time. Patient can be on some simple tablets. It's something similar to how we treat blood pressure or diabetes. Take some tablets, be at home, come in once in 3 months, and like that will be going on for long duration of time. So that is a specialty with the prostate cancer. It's got something to do both with the disease biology as well as the treatment options available. Now, as compared to other cancers, the prostate cancer is indolent. That means it is not like within 1 month or 2 months it's going to spread like wildfire. So it is one of the slowly growing tumors. In fact, if we say if we do autopsy for patients who have died after 90 years for some other reason, around 10 to 20% of them, 20% in fact, will have some focus of prostate cancer in their prostate. So it is such a disease. So after 80, if we do autopsy in those patients, around 10% of the patients may have a focus of prostate cancer in them. So it is an indolent disease, and with the diagnosis of CA prostate, it is almost treated like an uncontrolled hypertension. Okay, so and that is because the disease is indolent. Another reason is there are a variety of treatment options available, especially hormone therapies. We need to understand that prostate cancer is hormone driven. So the testosterone is a male hormone which drives growth of prostate cancer cells. So that since it is a hormone driven, there is a hormone therapies which are available. It can be surgically, production of testosterone can be stopped by removal of testis. We call it as a bilateral orchidectomy. Or we can give some injections which will be given once in a month or once in 3 months, just under the skin, subcutaneous injections, which will chemically induce castrate status, we call it. That is a blocking of the testosterone will be done. And these are all simple treatments. The good thing about these hormone therapies is patient will be sort of disease free or symptom free for quite a long period of time. Once they respond, they are going to respond for long duration of time. So I would say it's a chronic disease. Prostate cancer, even if it is in the stage 4, is more than a cancer, it is a chronic disease. So there are a variety of hormonal agents which are available, which will block the testosterone production. And even if there is something called a small amount of testosterone which can be produced in the the body fat cells, even that can be controlled by simple tablets. So that is the advance in the treatment, and yeah, it's more of a chronic disease than a cancer. Prostate cancer is what
I think very well brought out that we are talking of prostate cancer being a chronic condition, and testosterone is the fuel which drives it. It's another matter that prices of the actual fuel in the country are going up. I don't know if it may actually become more than the cost of hormonal agents that we use to block the fuel of testosterone in cancer. But just for the general public, to block to block basically testosterone and cause testosterone suppression, as medical oncologists, we use injections either monthly or 3 monthly, or like Dr. Harish said, we refer to the urologist or the surgeon for removal of the bilateral testis to suppress the production of testosterone. Again, a lot of stigma is associated with the word castration, because in medieval times, or as penalties, castration was actually a penalty. So somewhere in the oncology and the medical community, we sort of start needing to think about renaming things so that it does not cause a psychological impact on the patient. But nowadays, beyond hormonal therapy, we now even have tablets which can be added. And of course, chemotherapy is already there. So I'd like to ask Dr. Neeti with regard to the tablets which are available, which are sometimes added to the hormonal therapy in stage 4 disease for the treatment of prostate cancer.
So I think wisely summarized by you and Harish that, I mean, basically, prostate is a hormone-driven cancer, and the first therapy is always anti-hormones, and it begins with complete androgen blockade. This could be medical castration or it could be surgical castration. And when we are talking about medical castration alone, they can be luteinizing hormone, releasing hormone, agonist or antagonist. And even in this form, now we have certain tablets. Instead of injectable, they are tablets which can be used to suppress the luteinizing hormone, which actually promotes the testosterone in the body. Along with this, we try to give anti-hormones as tablets. Now, these higher generation anti-hormones could be in the form of androgen blockade drugs. The two important drugs which are available in the market are abiraterone acetate and enzalutamide. These are, I mean, this is the third generation hormones which are available and generally given along with LHRH or surgical castration. Now, beyond this, also there are quite a few drugs. Nitin, you want me to discuss other options of managing castrate-resistant prostate?
In brief, we could just have a brief in the last
So
few minutes, briefly.
yes, whenever we are planning treatment of metastatic prostate cancer, the first important thing is to look for biologic fitness, and the second important thing is look for tumor characteristics. So with the combination of all of this, we start with hormones, and then once that mechanism of action shows some resistance or stops working, we switch to other mechanism of action. So generally, if we are starting with hormones, we'd like to take up with chemotherapy. If we have started with chemotherapy, we'd like to switch to hormones. With change of mode of action or change of mechanism of action, generally the response is better. And now we think of newer drugs which are targeting genetic mutations, as we have discussed in the past, or we have immunotherapy options if there are certain tumor characteristics again, which makes them sensitive to immunotherapy. And then now we have newer generation targets and also drugs which act through radionucleotide. So we have lutetium therapy and actinium therapy, which are again radioactive molecules which are given once or repeated every 3 months or 6 months to kill the circulating tumor cells and, of course, to reduce the tumor burden.
So to sort of just summarize the treatment that we follow at our center at Manipal is that, like Dr. Neeti also rightly said, and something followed across oncology centers, is look at the patient fitness, look at the burden of the disease, very important, decide whether we would use a single agent hormonal therapy or try to add other ways by which we can have androgen blockade. And once, and I think this is a term we have used a lot in this discussion, castration resistant. What does castration resistant mean? It's essentially when despite blocking testosterone, the tumor is still growing. And that's where sometimes the role of chemotherapy comes in if we have not used it before, or like we already discussed, the genetic mutations, PARP inhibitors, which can target BRCA or immunotherapy comes in. So I think we are coming to the end of this wonderful session. I would just like a last thoughts from all the speakers. I would like to start off with Dr. Ravi with thoughts on what should be done to sort of increase awareness of prostate cancer in India. And also, if you could just briefly touch upon the role of genetic counseling, and do you think referral labs should be offering genetic counseling for patients with prostate cancer?
I think this last question is a very important question. I think referral lab really have to play a very important role. What I like to say here is a single standalone PSA value, which is high. I think don't get worried about it, but get your routine screening done, especially after 50 years of age. If that's one, if you have a symptom, definitely get it done. But overall, the patient should be counseled that single isolated PSA value should not be taken in cognizance. A lot of other clinical examination, the symptoms, the family history, digital examination. I think entire thing in totality, they should go back, and that we should tell them, don't get panicked by the single value. Go back to your oncologist, go back to your doctor, think about it, have an isolation, probably, and do some maybe other testing, free and pro-PSA testing, so that you have a prostate health index kind of be created, and that is, and nothing to worry. It's a chronic disease nowadays, as Dr. Harish mentioned. I think is as good as somebody having a hypertension or a MI. Probably they can survive 20 years. So nothing to worry about it.
Dr. Harish?
So, so before saying anything, I think we should all understand that prostate cancer is around 10 times less common in our country as compared to other Western countries. Incidence is around 10 times higher in Western countries. So there will be sort of screening programs for them, which will be sort of mandatory. Around after 45 years, they'll do annual PSA screening. Now, there have been issues with the screening as well. So it's okay if we don't do screening as well. First of all, the general incidence itself is low. But anytime, whenever we have any symptoms, so symptom-directed screening of PSS can be done, which sort of so it gives us an opportunity, since we know that prostate cancer is an indolent disease. So early, it gives us a time to identify at an earlier stage, and so probably we may use little less treatment and which will be probably will be going more to achieving more cures by detecting. So yes, screening is not mandatory, but if there are any symptoms, it would not harm to undergo screening test for CA prostate, and it is an indolent disease. That's from my side.
Dr. Mohan? Dr. Mohan, if you could have your...
I would suggest a PSA annually, age greater than 45 on your birthday. And that is what I advise everybody I meet. If there's a family history of prostate cancer or any other relevant cancer, age 40 onwards, do a yearly PSA. PSA is cheap. It's a good screening tool. It is available across the country. It is not like when I came back from Canada first. It's not expensive. It's not big city driven. So do a PSA on your birthday. That's the best gift you can give yourself.
All right. We'll come to the gentle lady on the panel to give us the perception on men's health in the month of November. Dr. Neeti, your closing thoughts.
So, yes, as everybody pointed out, it's not amongst the first 10 common cancers in our country. It's the 12th most common cancer. But I think it's grossly underreported. We have a hidden figure which we don't know about. So all I can say is, at any age starting 40, go to a doctor first, get yourself evaluated, and let them write a set of investigation based on your personal history, based on your family history, and your occupational history. Let them write what is specific to you when you need a stool examination, a PSA examination, a DRE, or whatever it is. And second, an important thing which we should all understand is that most cancers are lifestyle driven. And prostate, again, is a very important lifestyle cancer. A good, healthy lifestyle definitely makes a difference. Thanks, Nitin.
Right. So with that, we have come to the end of discussion of the prostate cancer. To just summarize what our esteemed panelists have said, let's not be worried about a diagnosis of prostate cancer because it's more of a chronic disease. Hence, do not ignore symptoms for the fear of being diagnosed with prostate cancer. Meet a urologist or meet a urologist to get urinary symptoms evaluated. Screening PSA, especially if there's a family history. And yes, do not be alarmed by a screening PSA report. Again, meet your doctor and let the report be analyzed based on various other clinical conditions. Lot of investigations available for staging. Molecular genetics such as Drca and eligibility for immunotherapy genetic testing now being done by oncologists across the centers. And yes, a plethora of treatment options available. I see some comments and I think we have answered most of those questions. And like I said, Dr. Neeti also talked about it being a lifestyle disorder and how to have a healthy lifestyle to avoid and reduce the risk of getting. And I think we have really answered most of the questions which have come in the content section too. So thanks again to Voice of Health for organizing this very important discussion on men's health in the month of November. I'm not sure all the gentlemen of us who are present here who are going to be brave enough to take the challenge of No Shave November because we of course have hospital and patients to see. But yes, I think let the awareness for prostate cancer be out there. If you have any questions, you can always drop in the chat box or the comments, and one of us from our respective centers would definitely try to answer it. I'm Dr. Nitin Yashas from Manipal Hospital, Jayanagar and Sajapur, thanking Dr. Ravi from OnQuest Labs, Dr. Neeti, Director of Fortis Oncology, Dr. Harish from Senior Consultant Medical Oncologist from SiteCare Hospital, and Dr. Mohan, Senior Urologist and Head of Urology at Fortis Hospital, Bangalore. Thank you all so much for joining this. I hope this discussion was enriching.
Thank you so much.
Thanks.